Okay, so now that we've gotten through the wellness topics related to sexuality, it's now time to move on to the common problems affecting sexuality. In this voiceover, we're going to tackle sexually transmitted infections, dysmenorrhea, sexual response disorders, and a few other topics. This is just a list of the topics that we're going to cover in this voiceover. We're going to cover topics affecting sexuality, such as sexually transmitted infections, dysmenorrhea, premenstrual syndrome, negative intimate relationships, sexual harassment, rape, and sexual response cycle disorders. We're also going to talk about sexual health and aging. So unfortunately, not everything can go smoothly for everyone, and there are many problems that can affect sexuality. These issues can occur in loving, healthy relationships or in abusive and dysfunctional relationships. It can be temporary or situational, or it can be long-standing. Here's a list of potential problems, and we're going to look at them in more detail in the next slides. Sexually transmitted infections are infections that are spread through sexual contact with the penis, vagina, anus, mouth, or sexual fluids of an infected person. The mucosal tissue of the genitals, rectum, and mouth are particularly susceptible to bacteria and viruses that cause sexually transmitted infections. Some STIs can spread skin to skin, such as with HPV, through blood or blood products, such as with HIV, hepatitis B or C, or from mother to baby during pregnancy or birth, such as with HIV. Some STIs are spread through autoinoculation, which is spreading the infection by touching or scratching an infected area and then transferring it to another part of the body. This is really common with herpes. Sexually transmitted infections cannot typically be transmitted from innate objects. It's important to note that many of the sexually transmitted infections are considered reportable diseases. This means they have a significant effect on public health. In the United States, all cases of gonorrhea and syphilis, and in most states, ours included, New York State, chlamydial infections must also be reported to the public health authorities. And in our case, that would be the New York State Health Department. The purpose for this is for surveillance and partnering notifications in an effort to prevent and control the spread of sexually transmitted infections. All right, so risk factors for sexually transmitted infections. Believe it or not, sexually transmitted infections are really common. It's estimated that nearly 20 million new infections occur in the U.S. each year. Some high-risk populations are women, men who've had sex with men, adolescents and young adults under 25, and victims of sexual assault. High-risk behaviors are having, new or multiple sex partners, having sex partners who have had multiple partners, sharing needles to inject drugs, or inconsistent or incorrect use of barrier methods. Nearly 2/3 of all sexually transmitted infections actually occur in people younger than 25. And media's emphasis on sexuality without mentioning safer sex doesn't help either. Substance abuse can impair judgment and increase unsafe sex practices. Some other high-risk medical history is not being vaccinated for sexually transmitted infections that have vaccines, such as HPV. Sexually transmitted infections, a lot of them have no initial symptoms, and the infected person can transmit the infection without even knowing it. For example, 90% of women with gonorrhea or chlamydia have no symptoms. Okay, so your textbook does a really good job going over thoroughly the sexually transmitted infections. But for this voiceover, I'm going to focus on a few of the most common ones. So it's HPV, gonorrhea, chlamydia, and herpes simplex virus. Okay, so we're going to start with HPV, which is the human papillomavirus. This is an extremely common sexually transmitted infection of the anal-genital tract. It's said that as many as 43% of all women ages 14 to 59 have HPV. There's actually over 100 types of this, and 40 types of them are linked to lower genital tracts of men and women. HPV is a known precursor to cancers of the cervix, vulva, vagina, anus, and penis, in addition to some head and neck cancers. HPV's role in cervical cancer is pretty well established. It's been studied a lot, and that is the type we're actually going to focus on here. HPV types 16 and 18 are known to be high-risk types linked to high-grade epithelial lesions, and they often progress to cancer. Low-risk strains are more commonly associated with condylomas, which is genital warts, and they're not typically linked to cancer or to cervical cancers. All HPV strains are transmitted by direct contact during vaginal, anal, and oral sexual intercourse, and therefore the risk factors are the same as those described in the previous slide. Cervical cancer is typically a slowly progressing cancer. It's honestly not a cancer that any woman should die from. There's very effective screening tools with the PAP testing and HPV testing and annual pelvic exams. Together with the HPV vaccine, the risk of complications should be eliminated with prevention and early detection. As nurses, it's going to be your role to educate women on the importance of annual well visits, the benefits of the HPV vaccine, and education on prevention of sexually transmitted infections. Chlamydia is the most common sexually transmitted infection in the United States. It's also known as the silent infection. This is because it's typically asymptomatic. It's not common for chlamydia to go undiagnosed until complications occur. For men who develop epididymis, they can actually have infertility issues. For women, they're at risk for developing PID, which is pelvic inflammatory disease, which can have damage to the fallopian tubes and increase a woman's risk for ectopic pregnancy, infertility, and chronic pelvic pain. The risk for PID increases with repeated chlamydial infections. The more episodes of PID, the more likely a woman is to experience infertility issues. Nucleic acid amplification testing is used to identify small amounts of DNA or RNA in test samples. It can be performed on endocervical or vaginal swabs from women, urethral swabs in men, and urine from either men or women. So now a patient tests positive. What happens? They obviously need to be treated with antibiotics. It's typically either a single dose of azithromycin or they can be put on doxycycline for 7 days, although there are alternative antibiotics for people who have allergies. This is a perfect teaching moment. In addition to teaching on properly taking the antibiotics, infected individuals also need to be counseled to refrain from all sexual intercourse for at least 7 days after treatment and until all sexual partners are completed with their treatment. A test of cure is recommended 3 months following treatment, and safe sex practices should be reinforced. We need to encourage patients to use condoms or other barrier methods consistently and correctly every time they have sex. So on to gonorrhea. 50% of affected individuals will display symptoms. In men, the initial site of infection, typically the urethra, which causes dysuria, purulent urethral discharge, rectal pain, bleeding, or purulent discharge. Women are typically asymptomatic, but some of them do have some minor overlooked symptoms that are listed on the chart. Because men are typically symptomatic, they usually seek treatment earlier and are less likely to have long-term complications. Women, on the other hand, typically don't have symptoms, and serious complications are more likely for them. Very rarely, men and women can develop disseminated gonococcal infection, which is associated with skin lesions, fever, arthralgia, arthritis, and or endocarditis. Neonates can also develop gonococcal conjunctivitis from exposure to infected mothers during delivery, which can result in permanent blindness. Because of this, most states, including New York State, require the use of prophylactic treatment in the eyes of all newborn babies shortly after birth. As far as diagnostics for men, a presumptive diagnosis can be made if there's a history of sexual contact with a new or infected partner, followed within a few days by urethral discharge. Women, on the other hand, need to be tested with the nucleic acid amplification testing or culture. So treatment for gonorrhea is usually dual therapy with what's called ceftriaxone. It's Rocephin. It's actually an antibiotic that's given intramuscularly and an oral azithromycin. Again, there's also alternatives to this therapy based on allergies and resistance. This is the teachable moment, and all the same topics discussed for chlamydia need to be discussed for gonorrhea, especially as far as explaining to your clients that they need to refrain from sexual activity for 7 days after they are completed with their antibiotics, and also ensuring that their partners are treated as well. Okay, so now we're going to talk about genital herpes. This is a lifelong incurable infection that is extremely common. It is caused by herpes simplex virus type 1 and type 2. Although both forms can cause genital lesions, herpes simplex 1 is more commonly associated with oral lesions, and herpes simplex virus type 2 is more commonly associated with genital lesions. When a person is infected with herpes simplex virus 1 or 2, the virus persists with the individual for life. Transmission is going to occur through direct contact with skin or mucous membranes when an infected individual is symptomatic or without any apparent symptoms with asymptomatic shedding. Risk factors for herpes simplex virus are similar to all the other sexually transmitted infections. Clinical manifestations vary, as does the frequency, severity, and duration of outbreaks. Complications are rare, thankfully, but can occur as listed on the chart. An important one that you should really know is that pregnant women can transmit this virus during birth. Women with a primary outbreak have the highest risk of transmitting genital herpes to the baby. The virus can affect the baby's skin, eyes, mouth, or the central nervous system. So an active lesion at the time of delivery is an indication for a cesarean section. This is to protect the baby from exposure. Treatment for genital herpes is antiviral medications. They don't cure. It just shortens the duration of the herpes simplex virus shedding. It shortens the healing time of the genital lesions and reduces the frequency of outbreaks. In counseling patients with genital herpes, it's important that they understand that it is a manageable condition and help them understand their treatment options. For some people, this can be a real devastating diagnosis, whereas for others, they may not be too concerned. You need to teach the patients with active outbreaks to perform good genital hygiene and wear loose-fitting cotton undergarments. Keep the lesions clean and dry. Pain can be treated with over-the-counter ibuprofen or Tylenol, and ice packs can be applied to the area for some relief. IV acyclovir is reserved for life-threatening infections in which hospitalization is required for the treatment of disseminated infections, central nervous system infections, or pneumonitis. All right, so moving on to menstrual disorders. Dysmenorrhea is painful menstruation. The symptoms and treatments are basically outlined on the slide. Some important things to maybe know to educate your client on how to deal with this could be, basically encouraging, rest, applying heat to the back or the abdomen, and taking NSAIDs for the pain. Premenstrual syndrome, this is a issue that occurs usually 3 to 14 days prior to menstruation. It's extremely variable in its clinical manifestations, but some of the signs and symptoms are listed on the slide. Some of the ways to treat premenstrual syndrome is really just, getting adequate sleep, eating small, frequent meals, trying to reduce the intake of sugar, caffeine, alcohol, and salt in the diet. So now we're going to move on to negative relationships, sexual harassment, and rape. These are some really private and difficult topics for men and women, not only to admit, but to discuss. Most couples are happy and their sexual relationships become more satisfying as they mature. Unfortunately, this isn't always the case. Not all relationships mutually satisfying. It can involve neglect, abuse, physical or emotional. Some couples are in celibate, loveless unions in order to really just have financial security, social status, sometimes for the sake of their children or due to restrictions, be it cultural or religious, on divorce. In reality, most relationships ebb and flow between satisfying and not so much due to a wide variety of factors. Negative relationships, on the other hand, involve domestic violence, also known as intimate partner violence. You guys will actually get a full lecture on this in your senior year, but we still need to cover it. This can involve physical or emotional intimidation, assault, or rape. It can affect either gender, but it's most often a man as the perpetrator. The anger, domination, and physical violence of the partner lead to fear, intimidation, and submission of the victim. The victims are often left to feel that they deserve the abuse and often won't admit it or admit to the cause of their injuries. Many abuse victims are dependent on their partner and don't feel that they have a way out. As a nurse, it's important to recognize these signs and offer help in a caring, non-judgmental manner. There is help out there for these victims. Sexual harassment. This occurs when a person in power makes unwanted sexual advances that implicitly or explicitly relate to the victim's employment, academic status, or success. The advances can take form in sexual comments or behaviors such as touching. Because of the power imbalance, the victim might feel like they need to be quiet about it, not say anything. They may be worried if they speak up that they will suffer physically and psychologically. Moving on to rape, this is a non-consensual vaginal, anal, or oral penetration which occurs through force, by the threat of bodily harm, or when the victim is incapable of giving consent. Rape is a violent crime that involves significant psychological and physical injury. 1 in 6 women and 1 in 33 males are victims of attempted or completed rape. In 2/3 of the cases, the victim actually knows or is related to the assailant, particularly in cases involving children. People with developmental disabilities, especially mental retardation, are at double the risk for sexual assault. Many rapes are going to go unreported, especially if drugs or alcohol are involved, but also due to the fear of the assailant, fear of consequences to the assailant, and knowledge of the low conviction rate for rapists, the desire to avoid trial, the shame or embarrassment, the past sexual history. Some people blame themselves. They often just have a feeling of wanting to move on, and they, maybe just have the desire to deny that the event ever occurred. In addition to the psychological trauma, rape victims are at really high risk for sexually transmitted infections and pregnancy. So now we're going to discuss sexual response cycle disorders a little bit. We're going to start with low libido or hypoactive sexual disorder. This is a significant decrease in or the absence of both sexual fantasies and sexual activity. It affects both men and women. It can be transient or long-term. Individuals experiencing low libido may be reluctant to engage in sexual encounters or just avoid all sexual contact. But once sexual activity is initiated, the individual is able to achieve an orgasm. Factors causing low libido include history of sexual trauma, negative attitudes towards sex, negative relationships, and biological factors such as hormones, perimenopause, or medication side effects. There actually are medications on the market that also help counteract low libido. Arousal disorder. This manifests as minimal to no pelvic congestion and vaginal lubrication despite the presence of desire. Dyspareunia or pain with intercourse further decreases sexual desire. It can be caused by vaginal dryness, such as with menopause, or a side effect of a medication. Other female causes include vaginal or urinary tract infections, pelvic inflammatory disease, and endometriosis. For men, dyspareunia is typically the result of a urinary tract infection or phimosis, a condition in which the foreskin of the penis is too tight, or balanitis, which is inflammation of the penis. Vaginismus is a rare female disorder affecting desire and arousal, and it's characterized by intense involuntary contractions of the perineal muscles, which close the vaginal opening and prevent penile penetration. This can be associated with psychological or physiological disorders. Erectile dysfunction, which is formerly known as impotence, is a male sexual arousal disorder. This can be persistent or recurring to either achieve or maintain an erect sufficient for satisfactory sexual performance. Common physical causes include diseases of the blood vessels, including hypertension, hyperlipidemia, diabetes, some neurological disorders such as spinal cord injuries, Parkinson's, or stroke, or endocrine problems such as diabetes. Psychological issues can also contribute to ED, such as performance anxiety, history of sexual abuse, relationship issues, and mental health issues. Additionally, some medications can actually cause erectile dysfunction as well. Moving on to orgasmic disorders, these are a delay in or the absence of orgasm after a normal sexual excitement phase. It is most common in young women who have not had adequate sexual experience to learn how to reach an orgasm. It's not uncommon for women to need manual clitoral stimulation, as not all women can achieve orgasm through intercourse alone. Men can also experience orgasmic disorders. Premature ejaculation is when a man reaches orgasm and ejaculates before, at the time of, or shortly after penetration. This can lead to disappointment of both partners and put a strain on the relationship. There are techniques and medication to help delay the ejaculation. In retrograde ejaculation, semen empties into the bladder rather than into the urethra. Normally, this cannot occur because the internal bladder sphincter closes in the orgasmic phase. However, some medications, prostate surgery, and spinal cord injuries may lead to retrograde ejaculation and ultimately resulting in infertility. So sexual health and aging, I did talk about this a little bit in the last voiceover. Menopause is the complete cessation of menses. It's diagnosed once a woman has gone 12 months without a menstrual cycle. Sexual problems are more likely due to failing physical health and medication side effects. Lack of partner. This is especially a problem for women. Lack of privacy, especially for those who live with other family members or in long-term care facilities. Postmenopausal women also commonly experience decreased sexual stimulation and desires, and therefore they may need more foreplay and direct clitoral stimulation for enjoyment. Additionally, postmenopausal women are also going to have issues with decreased vaginal lubrication and or experience vaginal atrophy, leading to dyspareunia, which again is painful intercourse. Over-the-counter lubricants can, help with counteracting vaginal dryness. Erectile difficulty can come with age as well, or as a medication side effect. Men may need more time and stimulation to achieve erection. It might take longer to ejaculate, and orgasmic contractions may not be as intense. Okay, so moving on to menopause therapy. Some women will transition through menopause without any difficulty, and some others will need to seek assistance for some of the discomforts that come with menopause. Such as hot flashes, interrupted sleep, or vaginal dryness. Some things they can do is make lifestyle changes such as balanced diet, losing weight, avoiding caffeine and alcohol, and avoiding cigarette smoking. There are some alternative medications that can be used, such as herbal supplements. Some women find acupuncture to be helpful. Menopause hormone therapy is also used, but all women that still have a uterus must also receive progesterone to protect them against endometrial cancer. It could just be estrogen alone if women have had a hysterectomy, so that means they don't have a uterus. Some contraindications for hormone replacement therapy include, those women that have a history of breast cancer or blood coagulation disorders, smoking, hypertension, diabetes, cardiovascular disease, and any renal or liver disease may also be contraindications. The hormone replacement therapy will include both oral medications in addition to patches, vaginal rings, and vaginal creams or ointments. Water-soluble lubricants such as KY liquid, Replens, and other over-the-counter products can help to relieve vaginal dryness. There's also estrogen alternatives, including botanical preparations, which are options for women who don't want to or can't have hormone replacement therapy. These should be discussed with their healthcare provider because they may interact with some of their other medications. Kegel exercises can increase muscle tone around the vagina and the urinary meatus to counteract the effects of genital atrophy. If you're unfamiliar with Kegel exercises, I would just suggest that you look them up. Increase hydration. It's necessary to decrease the concentration of the urine, flush urine from the bladder, and reduce bacterial growth, thereby preventing UTIs. Proper hydration means at least 8 glasses of water a day. Proper perineal hygiene. This includes wiping from front to back after urination and defecation, and to reduce transfer of bacteria to, again, prevent cystitis. All right, moving on to osteoporosis. We discussed this a little bit, but one of the greatest hazards of postmenopausal years is osteoporosis. It results in the increased spaces in bones, which increases after menopause. The decrease in estrogen at menopause accelerates the bone loss and slows the bone regeneration. Osteoporosis is characterized by decreased bone density, leaving bones porous, fragile, and susceptible to fracture. Vertebrae and hips are the most common sites, but you can have osteoporosis in the wrists, forearms, feet, and toes. In the United States, 1.5 million osteoporosis-related fractures occur annually, women being at the highest risk, although men still can suffer from osteoporosis. Some predisposing factors include small bones, fair-skinned white women of Northern European extraction. Additionally, Asian women are at high risk. Other factors include family history, late menarche, early menopause, sedentary lifestyle, smoker, alcohol use, excess caffeine intake. Some drugs can also reduce bone density, including corticosteroids, some anticonvulsants, and some aromatase inhibitors for breast cancer. Inadequate lifetime intake of calcium or vitamin D is also a risk factor as well, because peak bone mass occurs at near age 30. Manifestations of osteoporosis, it's actually called the silent thief. That's because these changes occur over the course of years without very many symptoms. Typically, the first notable change is a loss of height and back pain from vertebral collapse. Some later signs can include the Duager's hump, which is when the vertebrae aren't able to support the body in an upright position. So the diagnosis is made based on history, physical examination, and bone mineral analysis, which is performed by a DEXA scan. So we're going to review erectile dysfunction. It's the inability to attain or maintain an erection that allows satisfactory sexual activity. It affects more than 30 million men in the U.S. It can occur at any age. About 50% of all men between 40 and 70 have some degree of erectile dysfunction. This increase has been attributed to substance abuse, stress, anxiety, chronic medical conditions, or their treatment. Erectile dysfunction can be caused by a multitude of factors, including cardiovascular disease, smoking, obesity, stroke, spinal cord injury, neurological disease, diabetes, liver disease, low levels of testosterone, or prostate and or rectal surgery. Some common causes include vascular disease, side effects from medications or recent surgery, trauma, chronic illness, stress, or depression. Some clinical manifestations are typically self-reporting of the problems. Men will state the inability to achieve or maintain an erection. This can occur occasionally or continually with gradual or sudden onset. The gradual onset is usually typically due to physiological factors, as opposed to sudden onset is commonly associated with psychological issues. It's common for younger men to seek treatment for erectile dysfunction after being diagnosed with diabetes, hypertension, or depression. Erectile dysfunction can cause great distress in a man's interpersonal relationship and make him feel like less of a man. It can also cause relationship issues, which can lead to anger, anxiety, depression. The diagnosis really begins with a thorough sexual health and psychosocial history. There are several self-administered assessment questionnaires that are available. The physical exam, which will likely be performed by the healthcare provider, is really going to focus on the secondary sex characteristics. The treatment goal for erectile dysfunction is really for the client and the partner to have a satisfying sexual relationship. Some treatments that can be used for men whose erectile dysfunction is of psychological nature, they should be referred to counseling. This can be with or without their partner. Ideally, he should seek out a qualified sex therapist. As far as medications, there are erectogenic drugs. They're all PDE5 inhibitors. These drugs cause smooth muscle relaxation and increase blood flow to the corpus cavernosum, thus promoting erection. They can be taken PO prior to sexual activity. They're generally safe and effective, except in the absence of arousal. Side effects can include headaches, dyspepsia, flushing, nasal congestion. Some examples of the PDE5 inhibitors include sildenafil, which is Viagra, and tadalafil, which is Cialis. Please remember that these medications should not be taken with nitrates, which is nitroglycerin, in any form at any time. Okay, so we have completed the voiceovers on sexuality, both wellness and the issues and concerns related to sexuality. If anybody has any questions on this voiceover content or any of the content in the previous voiceover, please feel free to reach out to me. I have no problem meeting up and going over anything you want to review.